Hey guys, this is Daniel. We have a new microphone set up, and I unfortunately messed it up, so Michelle's voice sounds like she's talking into a can. We didn't realize this until post-production. The audio is good enough for you to hear. We are truly sorry, and we'll have it fixed for next time. Thank you for your support. Enjoy the show. And welcome back, everybody. We're finally, I know we keep saying this, that we're finally getting consistent again, but we've, as you can see, addressed some technical hurdles. So things are running much smoother now. Our mics work, the cameras work, the software works, everything works now. Everything's the way it should be. We don't have to sound like we're talking in a tin can anymore. We're here. So, had a little excitement this evening before getting started here. So long story short, one ceiling fan in here has given us trouble for a long time, but we've been able to use the light portion of it, the lamp portion of it. Well, tonight that stopped working, but it let out a little bit of smoke. Which is funny because I think the way these I want to see if I can change the way these videos are. I think on the screen we'll look like we're looking in opposite directions when we look at each other.
That's funny.
Yeah, I think that's how it worked last time. Anyway, so the light fixture started smoking underneath the ceiling fan, and so we of course turned that off. Did a quick check. I went to climb up the ladder to the attic to take a look and make sure nothing was on fire. And I thought that I had skipped the step on the ladder. That's the weak one. Well, apparently I went full force on that. And yes, I have lost some weight lately, but it was not prepared to handle all of me. So it lasted long enough for me to get my other foot up and then caved in.
Mind you, this man saw that the ladder was not doing this; it was doing.
Well, it always does that. That ladder has always been janky.
It bends as much as my elbow does.
It's always been janky. So anyway, I got some nice long, Wolverine gashes in the side of my leg that somebody was a little upset at me for.
Yes, because I'm supposed to die first.
So, yeah. But anyway, so we're here. My leg's all wrapped up.
You cannot expect me to see you bleeding or one of the children and just be like, oh, it's fine.
It'll be all right. It'll buff.
Sure, so anyway, answer for everything.
Because it will. Everything buffs out eventually. So anyway, we are wrapping up. Finally, I think we're
2 months
later. 2 months later, yeah. What should have been a month is 2 months later. We're wrapping up the discussion about the troubleshooting core values. And tonight we're talking about clinical discipline, which is one of our personal favorites because every time you talk about it, there's something different to unpack about it.
And someone gets mad.
Yes. You would think that accountability would be the one that pisses people off more, but I think this one actually is a little more bothers people because we touch. So anyway, we kind of want to follow our traditional pattern of dealing with problems and then addressing solutions. So and we're going to do it one for one. So one problem, one solution. So anyway, let's jump right into our problems because we have lots of them. Not really. We're just dealing with 4. We just hit four highlights.
Okay. So the first one, which you would think would be common sense, but is less than apparently, prioritizing sequences of events on a scene. And sure, there's a little bit of truth to the fact that the National Registry assessment sheets we do technically naturally follow if you're doing your job appropriately. Some stuff just might be, simultaneously. But this seems to be an ongoing problem that whether people just think that they can, that their way is better and, screw the norm, or they get too excited. We often see they get too excited to do like more advanced stuff. And a lot of people forget their ABCs.
Tunnel vision.
Yeah.
It's, it's whether you're it manifests a little bit differently with different certs. EMTs, where this can present a problem with them is like, sometimes it can just be overwhelmed and they just start grabbing at shit to do and everything's out of order and you can tell them and they hear things, they acknowledge things, but they're still in la la land. And you need to be like, hey, get it together, get a grip, take a deep breath. We got shit to do.
So I think you have that issue more with EMTs. They're eager. It's just, especially if they're newer, they're not as experienced, or if they haven't been in a busy or progressive service, they're not used to doing a lot of things all the time. So with paramedics, it's very easy to get tunnel vision and to jump to, hey, here's all the like crazy shit that I have to do for this call and all these wild things, but I forget, oh, hey, by the way, you got to make sure they're still breathing. With advanced, and you and I have differed somewhat on this conversation. In the grand scheme of things, I do believe that advanced EMTs are more useful in certain environments than others. Maybe not 911 EMS as much, but it's as you've put it, it kind of puts you in a weird spot of some more things, but it's not the full picture of what you get as a paramedic. So it is easy to get sidetracked because you're mostly an EMT, but you can do some extra stuff, but you're still mostly an EMT. So it's easy to get caught up in the cool factor of, oh, well, I can do these new things now. Slow it down. And as you can probably tell, there's a story behind all of this that we'll get to.
They might not have been able to tell.
Yeah.
The kind of call really saddens me.
Yeah.
Let me put out there, we're sharing a story, just as a sidestep, we're sharing a story between problems and solutions. I want to know what call type you think it's going to be. Stop it.
Anyway.
There's just a
You really think they don't know? You really think they don't? If you have a shit show call,
really bad RSIs.
They usually turn into cardiac arrests.
My brain bleed lady.
You get the point.
With me.
Yeah, but and so sometimes the misprioritizing is a genuine mistake. It's you're getting caught up in the moment, and you just need to get a grip on yourself, because that's ultimately what clinical discipline is about. Is you are, for the purpose of providing clinical care, reining in your emotions, getting control of your shit, running the call, and not letting it run you. There are also people who want to dick measure. And this becomes a problem because it's very easy to want to show people that you do actually know what you're talking about, to give the appearance of being all that in a bag of chips when you're not. Maybe you're trying to impress providers. Maybe you're dealing with, you think that people are thinking about some of your mistakes more than they actually are, and you're trying to salvage your reputation. Whatever it may be, all of that needs to fucking stop. All of that needs to fucking stop. When the tones drop, you have a job to fucking do. Fucking do it and carry on with your life. Listen to people, act decisively, but make sure that you're doing the appropriate interventions, the appropriate things at the appropriate times. It's not fucking complicated.
You would think. So for number 2, we have a lack of investment, and this comes from the providers and the agencies. So in the original clinical discipline that we did, over a year and a half ago.
Almost a year and a half ago, yeah.
Almost a year and a half ago. We talked about 3 primary levels of maybe not even levels. Level's not a right word.
Just types of investment.
Types of investment throughout our career. And they were your initial investment. So this comes down to us as providers are initially investing in ourselves for our education, our quality of education, how seriously we're going to take it. We're investing in ourselves in initial education. Well, then you move up to your didactic investment, which comes down to providers continuing classes, so recertifying your classes. As instructors, we also invest in other providers by providing that didactic. And I would argue that I wouldn't remember a lot of the stuff that I learned in school as well as I do in recall.
He's really good at that.
If it wasn't for teaching it, because it's your repetition that keeps it in. Then the third level of investment that we talk about is mostly the agency into the provider at that point, but it's also the provider. The corrective investment is where like remediation comes, where if you have to go through any other testing, if you get in trouble, maybe flagged like for a QA, like have a clinical issue, that is where the agency and yourself should be reinvesting in correcting whatever the problem was, whether it's a learning moment, a teachable moment, um, learning how to handle and prioritize your sequence of events. Like, I mean, pick something. But the wild thing is, at any point, we can go through, no matter how many years you've been in EMS, you can go through all of those again. So if I decide that I'm going to go get my GEMS, geriatric emergency medicine, certification, I am in my initial investment again. I am initially investing into my education while I'm getting this new certification. Well, then I move into didactic, where my instructors are going to continue giving me feedback while I am researching that and using it. So the lack of investment is people not investing in themselves. And honestly, we have these, salty providers that don't want to do anything within EMS anymore, but they, haven't made connections, so they go into education. And I'm not saying that's everybody. Please don't get me wrong. That's not everybody. Some of us love education. But if you have people that are just salty and just doing the job because they have to, not because they believe in it, then you have a lack of investment there.
Well, and you also get a lot of people that come into the job that just don't. They're here for the ride, but they're not. They didn't even start invested. It's not like it's an ongoing thing. There was not significant investment up front to begin with. So why are we surprised when they get a month into their career and they're already fucking shit up because they don't care. They didn't care to start with. So then this is just a job, which it is a job, but you need to treat it, I guess, more special in a way.
Well, and I think where we start to see issues is it's more so in the corrective investment phase of things, but I mean, you can have it during didactic, is when, let's say, I'm the QA person that's QAing your chart, and there was something clinically wrong, and we go into it, to have a conversation. Well, first of all, I should be calm and collected with, very professional, straightforward, like, hey, here's the issue, here's how we fix it, and, move on from there. So, the person talking to the provider has to remain professional. But also where we see issue is the providers. When we're in that corrective investment and we're getting talked to about something, there is a way to explain or justify, whatever, something that you may have done. And then there's like toxic defensiveness, where simply because somebody else said like, hey, this isn't how this should have been done, you immediately take it like a personal attack. Like, you take it as if I'm shunning you, your mom, your cow, and everybody.
Dishonor on you, dishonor on your cow.
Literally. You take it as if I'm attacking your entire like family line because I told you, hey, this isn't how this call should have been run. So like the toxic defensiveness, and we see it too, even within the didactic investment of everybody, where, people might be trying to invest, updated information to you. They read a study and it's like, hey, AHA might be bringing, this to the table or this change or whatever it might be. But if you have the toxic defensiveness and you're like, well, I have more years of service than that person, how are they going to teach me how to run ACLS when I've been doing it for blah, blah, blah? And like, it's possible for you to not know everything. And that's true for everybody. Again, something I actively preach. Doctors have specialties for a reason. You can't know everything.
Well, and let's just say you were magically able to teleport a doctor, or okay, well, let's make it a little more fanciful. Let's say you had some doctor who was, I don't know, a fucking vampire that, just existed in a cave for, the last 200 years, who was a doctor. Okay. I'm pretty sure their clinical knowledge from 200 years ago doesn't hold a fucking candle to what our clinical knowledge as paramedics is. So, okay, that's an exaggerated time frame and hyperbolic, obviously, but the point being, so much has changed in the last 200 years of medicine You think stuff might be changing even like on a 10-year level, a 20-year level? Yeah, a lot of fucking shit's changing. So just because you've been in this since, Moses doesn't mean that you don't have new stuff to learn, that the new people can't teach you stuff because it's constantly evolving.
Honestly, I think my favorite thing that I learned from this past paramedic cohort, even in the short time period since I went to school, is there's a literal formula to tell you how you should ventilate your patient based on environment. And like, I actually started bringing that into when I teach ACLS, and like, I have blown people's freaking.
I never learned that shit. Yeah.
I didn't either, and I didn't go to school that long ago. Like,
Yeah.
it's the coolest thing ever. And so, like, learning this formula and sharing it, like, it blew my mind. And I had somebody the other day that was just like, "Oh my God, my life is changed. We don't just go anymore."
Yeah, no. Yeah, no. It's not like on TV. Whereas, no.
I can't firefighter two-hand.
Listen. They tried. I'm just kidding. We love you guys.
Listen, I loved my guys the other day.
Yes. I will happily take a firefighter who is not certified that is willing to fucking work over an EMT who's like, nah, why do I have to get up for this? Because it's your fucking job. Anyway. So just a little bit. So third problem that we run into, and this isn't so much medicine related, is it's where we bring our home problems to work. Now, I get it. You're having a shitty time at home. It's going to bleed over into work. I have had plenty of times where I've had to come in and I've had to tell my partner right off the bat, hey man, I'm dealing with some shit. I can't, I'm working on it, and I'm sorry if I'm snippy, or I'm sorry if I sound distant. I had this conversation with a student, not terribly long ago. I was like, hey, I am normally so much more involved with you guys. I just have a shitstorm going on right now, and which obviously turned out well for us, but I'm not going to be as involved today. And that's fine. Like, you're setting expectations and you're communicating, but when it's my life's a train wreck, I'm dating a stripper and I'm on pills, but I don't want anybody to know about it, and I'm a shitbag.
I also add cocaine or.
Of course, then that's a whole different set of bringing your problems to work. And I think it's another issue we have where, yes, okay, EMS is a very elite community. When you look at the numbers, we're a very small subsection of the workforce, period. So it's natural that we gravitate towards each other, just like Navy SEALs all like to hang out, Army Rangers like to hang out, fucking, biologists like to hang out. Like, we naturally want to be together, but we sometimes get stuck where we blur the lines so much between home and work that we let the shitstorms in our personal lives dominate our attitude and our performance and our behavior at work. And it's unprofessional. And yes, we're human. You're going to have emotions. Shit's hard. We're all having a hard time out here. Doesn't give you an excuse to be a shitbag when you show up to work. Not at all.
Well, and like what you were talking about, telling somebody like, hey, I'm just having a day, I'm going to be kind of quiet. Like, you can have your feelings at the station as long as you're not taking it out on your partner, but also not letting it rule your behavior without annoying frequent flyer at 2:00 in the morning. I'm pretty sure that I can say all of us are annoyed with those, period. But it doesn't mean the frequent flyers can't actually have a medical emergency. You can't let it, you have to have emotional regulation, which when you start talking about emotional regulation, it also pisses people off. And it's like, okay, getting raging mad and not being able to control your emotions is so immature. It's just awful.
Well, it's look in the mirror. Would you be okay with someone talking to you or your loved one the way that you're talking to patients when you're in this space? It's a simple litmus test. Would you be okay with it? If you would be pissed off and want to choke the life out of them, You probably shouldn't be doing it. You probably shouldn't be treating people that way. I don't know. Revolutionary concept. It's not fucking complicated.
Yeah, but unfortunately, I can see people just like with the pain management conversation. Oh, well, if they're mean to me, then I'm going to be mean back, and they're going to get what they did.
Oh my god, it's this fucking 5th grade. What the fuck?
You know what? I had a supervisor not that long ago. She was talking to somebody else, and she goes, I feel like I have a bunch of elementary school kids here. And they were like, why not high school? And she's like, I'm pretty sure preschool's worse. And it just kept going back and forth, trying to decide what age grouping of immature children we are.
For real. And we glorify it. That's the other thing that I just don't get. Like, we glorify our immaturity. We glorify our emotional dysregulation. Why? Why? Where does this lead you? It's like it's this weird street cred that we build with each other, and it's fucking retarded. Like, sure, we can commiserate. You're having a shitty day. Cool. Express that you're having a shitty day. Like, joke around with each other. Bullshit a little bit. Fine, but it should be game face when you're dealing with patients. Period. Don't bring your shit to them. Because guess what? They clearly, because you're there, they have shit going on too. How many times do we walk in the middle of situations that 90% of the problem is domestic? Or an old partner of mine said, he's like, when you really think about it, about 80% of our calls are psych in some way, shape, or form, whether it's, anxiety, just emotional dysregulation, all this stuff. Like, you say most of our calls are psych. A little hyperbolic, but get the point.
Yeah, but do you want to know something sad? There was one county that we worked for that would dispatch you out to an alpha priority 2 or 3, whatever, psych call, and you're like, okay, la di da. You're scrolling through scrolling through the call notes, and all of a sudden it's confirmed overdose with a whole bottle of Benadryl, and you're like, what the fuck? I literally called dispatch after that one, and I was like, how is this coded as a psych call? And they're like, well, you have to be psychotic to take the Benadryl. And I was like, okay, but the chief complaint is an overdose regardless of cause, and you dispatching me non-emergent. Oh, you best believe she was symptomatic as shit. Anticholinergic overdose by the time we got there. And I was like, oh, that's nice. And pretty much, she took the butterflies at that point. That's this one shit right there.
There's a sign that I want to get, whether I put it in my house or eventually in an office one day. It says, please don't lick the windows. Because I'm pretty sure most of us are behavioral cases too.
Okay, but listen, when those of us were getting anxious in paramedic school about our exit interviews with our medical director, and we knew that he was gonna be hard as shit, and he was unfairly hard. So he was awesome, but it still sucked. Literally, when we asked him for advice right before that, his answer to us was, "Put on a helmet and lick a window. That way we get the safe and the stupid out of us." Or no, so we get the stupid and feel safe.
Which is hilarious because my exit interview was like the easiest fucking bullshit ever. We had like a brand new medical director, and so I mean the program we went to is supposed to be a complex oral board scenario that you went through with medical director that was supposed to test your knowledge and your problem solving. No, I know. I'm talking about mine. My patient was a mildly symptomatic sinus bradycardia.
Did you get back?
And that was it.
Did you get back?
I don't even know if I got that far. Like, I think it was literally just like O2 and fluids and consider atropine as needed. Okay, cool. Like, I was waiting for the other shoe to drop. Like, so when is the patient gonna collapse and code, or when is their eyeballs gonna start bleeding? Like, what's gonna happen? Nothing.
Did I ever tell you what mine was?
I know you did. I don't remember off the top of my head.
I wanted to cry this day. Mine was a 5-year-old, altered mental status. You get there, and what it was is he had overdosed on grandma's antipsychotic, tricyclic, antidepressants. Turned aspiration, turned respiratory arrest, turned cardiac arrest. He made you work it. You had to give amio, epi. It was a full VFib one. Well, then you get ROS, so then you have to do post airway management and ROS management with epi. And I was just like, literally, no matter what you did, it just kept getting worse. It just kept getting worse. And by the very end, he was like, "Why are you so worried?" And I was like, "Because it was Pete and you fucked my kid." Not like that, but you, you
Please don't delete us. Thank you. Sorry, YouTube. Even you have standards, apparently. I know.
I felt so screwed trying to do my pediatric scenario. But you know what? I passed, bitch. I passed that test. I was mad. because we were not allowed to use hand tabby or anything. Literally, you had a piece of paper. That was it. You had your brain and a piece of paper.
Which is more than some people have out there running calls right now.
Speaking of, another problem.
Yes.
Providers, prioritizing convenience over care. And what I mean by that, low-hanging fruit is when providers make up any excuse to force a patient to the literal closest facility, regardless of chief complaint. I cannot tell you how many times I did hospital clinicals for paramedic students at an ER that had a lot of missing specialties. And these crews knew it because everybody in this area knows what the hospital specialties are. And they would literally tell patients that they could go to this facility even if they had a cardiac issue, like a 3rd-degree heart block.
They're a 4x4 station. They're not a Band-Aid station. They're a 4x4 station, but that's about it.
Well, yeah, they could do surgery and stuff like that, but like there were a lot of specialties they didn't have in-house, like fucking cardiology. I can't tell you how many times people would be like, "Oh, well, they want to go to this hospital system, but that's like too far out of county, so we just kind of skipped over the county line and dropped them at the closest one." It's like, okay, but for your convenience, and I understand that if county is at level 0, status 0, whatever, that like that's a problem. But you can't take a patient to an incorrect facility when the other facility is less than 20 minutes away. Like it's not that big of a deal.
Yeah, and I see it too, where and it happens when you're making the decision to ALS versus BLS call, like not just in between EMS and facilities, but within the same crew. Like, yes, obviously there's a lot of gray areas, and all of us are going to be able to look at a call and have a different angle on which it's ALS, BLS, whatnot. I say that for the ones that aren't glaringly obviously ALS, like chest pain. But anyway,
what kind of chest pain? Because if I push in your chest,
I swear to fucking God, you fuckers that do that shit, fucking stop it. This whole well, does that hurt right there? It does. Oh, well, of course it's gonna fucking hurt. And you're putting your no, just don't fucking do that, because I'll tell. Well, and I'll use the example. Because I don't know. I talked about this on TikTok video. We haven't done a podcast since this happened, where I had a patient who I was doing a chest pain workup on, and I asked him to describe the pain, and instead of using his words, dude, man, puts up, and he's an older fella, so it wasn't like he was some big burly motherfucker that was actually going to hurt me, but he was slightly unstable too. He comes up and literally takes both hands and shoves my arms, and it's like that.
Daniel came out lucid from that
day. I'm quite proud of old Daniel. Would have been like a game fucking on. You're getting all the fucking drugs, motherfucker. New Daniel. I just looked at him very coldly and said, "You're not going to do that again." And he looked at me like dumbfounded, like I actually said that. And I said, "You're not going to do that to me." And I mean, there was a much lengthier conversation, but he didn't really like it. But I don't like people touching me like that. No, I'm not like, oh my God, I can't have people in my personal space. Like, no, I'm not that awkward. But like, I'm sorry, I don't like a random stranger just coming up and putting their fucking hands on me. So don't do that to patients. Don't do that. Just don't.
If you can't tell, I always know that train frame is something that Daniel likes to take down and beat people with.
Yeah. Well, maybe that's where I get just a little bit of roid rage. Maybe just a little bit. It just slips out right there. But anyway, that's just one example. There's so many when and it's not even just in your clinical decision making, but your bearing with patients, your demeanor with patients. Like, I know it's not fun to get woken up at 3:00 in the fucking morning. Believe me, I know. I'm there too. Like, I showed up to the same fucking party. But guess what? This is part of your fucking job, is being able to say, you know what? Yep, I would much rather be in bed right now. Pretty sure everybody would be, except the people on a 4-day meth bender. But anyway, but suck it up. Take the resting bitch, the purposeful resting bitch face, the intentional resting bitch face, the IRBF. There we go. The IRBF is fucking childish. Show up, help, even if it's a bullshit call, even if there's absolutely no clinical reason for you to be there. Show up, be a decent human being, and don't do this pouting, literal pouting. I have seen it over and over and over and over and over again. Grown ass adults, men, women, everything in between, all of them acting like fucking toddlers because they were inconvenienced to be here. I'm sorry, you're at work. Technically, it's all an inconvenience because you're not guaranteed to be doing any of your own personal shit. Sorry. So, even if it's a bullshit call, whatever, suck it up. It's what do we tell our kids all the time? Tough shit. Like, there's an expectation of how you're supposed to behave. Meet that expectation. Exceed that expectation. But don't do this whole whiny, bratty, I wish I was sleeping. Like, the most disturbing thing for me is if I'm in the middle of a shit. Like, if I can't complete a good shit and keeps getting interrupted by calls, okay, a little pissy. Just a little bit. But that's pretty much it. Like, as long as I can shit and at least finish what's in my mouth, I'm fine. Not at the same time. Not at the same time. But anyway, this is why they love us. So, when it comes to whether it's your clinical care or whether it's the way you are interacting with your patients, the other responders, your partner, step the fuck up. Be a mature adult. And if you can't, get some fucking help.
Well, and honestly, with this one, what I kind of want to throw in is people will take certain jobs, certain promotion situations, whatever, and they will want the status. They will want the, potential pay raise. I would hope if you're getting a different status change that you would get a pay raise. But like they want the perks of it, but then they don't want to have to do the full roles and responsibilities like job description with it. And that right there I just don't understand. Like you literally it's part of your job. I mean, there was a group of people that came through, or a group of students that came to do rides and everything. And I heard one crew talking about how they didn't want to deal with a rider that day because they had to study for their schooling. And like I get that, but when you're on shift, yes, it would be great if during downtime you could study. But like when you're on shift at work, part of your job is to have writers. Like ideally they're going to be with like FTOs,
Yeah.
PFS, etc. But I mean anybody at any given time can have a student. And like I'm sorry that you were wanting to study, but like you have a responsibility to teach that student because they're genuinely there for a ride time. It's not expected that you get to study when you're on shift.
Oh, magical idea. How about you pay attention when you're on calls and you might actually learn some stuff that's relevant to the studying that you're supposed to be doing?
Well,
Marvelous idea. Like if you that's the funny thing is a lot of times the people that complain the most about that stuff is the ones that just have shit for attitude. Like, oh, I want to be able to study. Well, then study the patient right in front of you because that is literally the best studying you can do, even if it's bullshit. Even if it's bullshit, that's still the best studying you can do is the patient right in front of you. Yep. Speaking of patients right in front of you, I guess you want to lay out your story that connects all of these dots for everybody and leads to our wonderful solutions.
Do you want to do that or do solutions first?
No, I'd say let's do the story. So kind of set the stage for this. And of course, you love good story time. Anytime Michelle has a shit call, especially when it's a cardiac arrest.
I know you guys are so surprised.
Shocker.
At this point, I'm pretty sure people on TikTok are like, does she run anything else? Yes, I do. I run good medical calls. Good RSIs and respiratory and
Yeah. But there's a call that you've run in the past that is particularly relevant to this conversation.
you know, we say that about every single one in every single situation is a fucking cardiac arrest.
Every single one of your situations is cardiac arrest.
What did I say?
You just said every single situation. I'm like, no. Every single one of your situations is cardiac arrest.
So I mean, this is the past story, obviously, along with all the others. But well, and
We have changed the names and dates to protect the innocent, the guilty, and the stupid.
I can't remember what the original three were, but
It was to protect the innocent, the guilty, and the incompetent. Yeah, that's what it was. I miss that intro sometimes.
yeah, right. Well, so as most of you know, if you've listened to the podcast for any length of time, fall calls are my least favorite kind of calls. Fall calls are never Granny split out of the chair and just needs lift assist. My fall call is, you know, someone was eaten by a badger and fell down the stairs and like lost a leg and like some of the most ridiculous shit that you're just like, but why? So, my crew was dispatched out to a fall call. And before they got on scene, it was upgraded to like a cardiac complaint. I think it was like heart problems, or it wasn't like straight chest pain. And you know, so they upgrade. I'm coming, and they get on scene. I get on scene like 5 minutes after they do. I walk in. I'm like, okay, they're on scene. It's a decent crew, or at least you know half of who I know. It'll be fine. So I didn't bring in any of my equipment because the expectation is first crew on scene, especially at 5 minutes into the call, should have their fucking bags and monitor.
I'm sorry, I have to throw this in there too because we would tie back into convenience over care. Bring your fucking bags in.
Yep. Daniel's gonna interject with comments.
Bring your fucking bags in. If you're the first one there, bring your shit.
Yeah, I'm not saying that you have to bring in the airway bag. Like if all of your stuff is across like 3 or 4 bags or whatever, I'm not saying you have to bring in every single thing. But like, come on, people. First in bag, monitor if you have one in the stretcher. Like I admit I don't bring the airway bag to every single call. I determine that
Allegedly.
What do you mean allegedly? They can bite me. I'm not taking an airway bag into a fucking like psych call. Like, not gonna happen.
I might need some O2 therapy.
I don't play that game. Anyways.
We're thinking of a different game, but anyway.
But I walk in and the patient is sitting like on the ground. She has a sling on, so you could tell that she'd had like probably rotator cuff surgery. And from where I was standing, she looked awful fucking pale. Like, and when she turned and looked at me, cool, pale, diaphoretic. If I was a betting woman, I would have bet she was having a STEMI / not glycemic, hypotensive. So I'm trying to get information from the husband. He's telling me that she has a history of AFib. She had surgery a week ago. She hasn't been on Eliquis in like 2 weeks, and she was fine last night. But she called him not that long ago, complaining of like feeling dizzy, like feeling off, maybe a little shortness of breath. So he came home. He got home, found her the way we did, and called for a fall call, but then upgraded to, you know, she's short of breath, chest pain, that kind of stuff. I'm like, okay, cool. Well, they're like trying to get her up off the floor, which I don't inherently have an issue with, but like if you have a hypotensive patient, lay them flat, sit them back up, and then stand them up to get to the stretcher, you might run into some problems like the pressure tanking. I've been there, done that with sepsis. Don't like it. So I asked them, I said, hey, before we do this, like let's get her on the monitor. Where's your monitor? We didn't bring anything in. What? You went to a cardiac complaint and you brought literally nothing in. I mean, don't get me wrong, they brought a stretcher, but they brought no monitor. They didn't even bring a manual BB cuff. When I say they brought nothing, they brought nothing. They brought themselves, their boots, and the stretcher. Well,
you are useless without your gear.
Well, I mean, without a gear, a paramedic is a layman that knows really good CPR. Like it,
You would think.
Well, okay,
We're being generous.
You would think that they would know CPR.
Yeah.
But point being, so my ass, who does not run, even when I was extremely athletic in swimming, I did not like to run. My ass was like, oh fuck. Literally ran out to the truck to grab a monitor. And by the time I turned around, they were bringing her outside on the stretcher. And I was like, fuck, at this well, I was like, okay, fuck. At this point, they made it that far. She was fine. We get her in the truck. I start putting the EKG on. She starts guppy breathing, and I'm like, fuck. I look at her pupils, they dilated, and she kind of turns and she starts kind of posturing. So I was like, seizure? She has no seizure? Kind of turn her a little bit, manually open her airway, and she stops breathing. I was like, shit. So we're checking for a pulse, have a pulse. The cardiac monitor showing it's bradycardic at a rate of like 30, sinus Brady. I was like, shit. So can't get a pressure on her, start backing. I try pacing her. Well, long story short, the pacing fails. Check for another pulse. By that time, I think we lost capture because she coded. So start start algorithms. Well, the problem at this point is I have an EMT and an advanced EMT on this call with me, and where I'm standing, it makes sense for me to do like the monitor and the IV and all of the things. But the BLS provider or the EMT decides that he's not sure about how he's going to back her and can't get the BVM together, and then is fiddle fucking around with the oxygen, and I'm like, just back her. And then he wanted to argue about stuff, and I was like, okay, well, somebody needs to do CPR. Well, the advanced EMT walks over across the truck to get the IV caddy and sits down and ties a tourniquet around this lady's arm. And at this point, I'm like, what the fuck? So I start doing compressions. Well, while I'm doing compressions, the only ALS person on scene, I call for a working cardiac arrest and look at the advance, and I'm like, what are you doing? And literally his response was, I'm in advance. I can do this. I'm going to do an IV.
That wasn't the point.
And, well, no. And I was just like, looking at her vasculature, her skin condition, her body, knowing her medical history, heart failure, CHF, like all of the things. I was like, we're just going to do an INO. We're not messing with that. I need you to come over here and do stuff. Well, while I'm trying to instruct the EMT what the fuck we're going to do, mind you, at this point, we finally have the patient on oxygen, but no adjunct at all. No biad, no OPA, no MPA. We got nothing. And I'm like, what the actual fuck? So finally tell the advance that we need to get the Lucas because we can't do, like, if the Lucas is on, we'll be fine.
If the paramedic on scene is doing compressions and there is a functioning charged Lucas that is not being utilized, there's a problem.
There's a problem. And when I tell you that the communication was, I need this now, multiple times, and it still didn't get done, there was a problem. So finally get the Lucas on, and then this child goes over, gets the IO, and drills her. And I'm looking, and I'm like, well, that's the wrong size IO needle. I wouldn't have gone with that one, but okay. I did not say this out loud. Like, don't get me wrong, I did not say this out loud. Well, finally, by that point, almost 10 minutes into the working arrest, we finally have an IO and people start showing up. Well, the advanced EMT basically steps away and stops touching the patient. My EMT stops backing the patient. And I call to my supervisor and I'm like, I need an airway right now. Like right freaking now, actually yesterday. And he's like, okay, well then the EMT and the SEMT are like, oh, we're going to drop a buyout. And at that point I was like,
we're gonna coulda, shoulda, woulda, too late.
I was like, it's fine. So fire's helping bag. We're doing all the things. It's a hot mess. Well, once I actually got hands in there that were willing to do things, the arrest went smoothly. Everything went in 2-minute cycles. I pushed all the drugs. I mean, the patient did end up dying. We ended up calling.
You'll have that on them big jobs.
Called it on scene, all the rest of it. But by the end of it, I was raging mad. Don't get me wrong, I am fine doing compressions. But when you're talking about BLS, ACLS, it doesn't matter what level care provider you are, it's always ABCs or CBA or CAB, excuse me. And that's what killed me about it is if you're an advanced EMT, fuck that IV. Do the airway. Go ahead and drop a king. Go ahead and drop, an ET tube for all I fucking care. The EMT could have, I would have done compressions and the EMT could have gotten a Lucas or vice versa. But there is stuff to do, especially in a witness to arrest. There is stuff to do before you go to a fucking IO. And I'm sorry, I'm very good at what I do. I am very good at slapping those IOs in there. And come to find out, the IO was incorrectly placed, which, in of itself, is an issue. But I was so mad by the end of it. We called it, I delivered death notification to the family, and we were all kind of standing around waiting for the coroner to come because, I mean, she was relatively young, like, probably surgery, all the things. And my supervisor went to leave, so I pulled him to the side and I was like, hey, here's what happened before anything else. Like, I called for help and everybody else showed up and such. And I was like, I'm really mad about this because this is a genuine training problem. And we kind of talked about like how to do the debriefing, and I even verified with him. I'm like, hey, if I've already given all the notifications to the family and we're literally just sitting twiddling our thumbs, what about doing it now in case I don't see them like later today or whatever? And he's like, abso-fucking-lutely. Like, you got to do it while it's fresh in a situation like this. I was like, okay, cool. So did all the things. We got into a really long lull. And when the cops finally kind of congregated in their own area, I pulled the crew to the side and I was like, hey, let's go ahead and debrief about the call. First and foremost, I gotta say, if you're going to a cardiac in nature call or, certain other call types, I was like, you have to bring bags in. Like, it as an EMT, you should be able to recognize when a patient is shocky, cool, pale, diaphoretic, repeating the same stuff, like obviously in distress. Now's not the time to fiddle fuck around on scene. Yes, she had to be picked up at some point, but like, if she was a peri arrest, which obviously she was, sometimes the best thing to do is stay where you are and try and initiate, to either prevent or, immediately catch it as it goes. And, just talked about the importance of bags and such. I was really fucking nice, if we're being honest. I should have been a lot meaner. But, not even meaner, but like stern. Like, hey, this is unacceptable. I didn't even say that. Just we talked about what should have been done. Then we talked about like what happened. I would have preferred to get the stuff inside because of the arrest, blah, blah, blah. No, I can't predict when somebody arrests, but in general, information collecting. So then from there, I was able to move on a little bit. And we talked about, once the patient coded that an IV or an IO, mind you, this dude sat down to do an IV first when I'm actively doing compressions and we still don't have an airway. It wasn't even necessarily about the IO, but just in general, BLS, ACLS, it is always going to tell you that early high quality compressions and defibrillation is the best chance that a patient has. Now, my patient was straight into asystole, but that's not the point. It was a witnessed arrest. It needed all of the BLS skills prior. And at the very end, I told him, I said, once we got everything placed and the Lucas on, like, that was a very smoothly run cardiac arrest. Like, I ended, in theory, on a happy note. And at the very end, I said, do you have any questions, comments, concerns, bitches, gripes? Do you have any feedback for me? Is there anything that I could have done better for you? I always end any of my after call debriefings like that. Well, then I hear later on that this provider, see, he was tight-lipped on scene. I could read that in his body language. What I didn't expect is to hear later on from that shift that he was telling, his partner and people that I was rude in my handling of it, and that it was unprofessional to debrief on scene when family was around, and that I just never should have said anything because he was doing his job. And at that point, it goes from like a corrective conversation, a corrective investment to, hey, let's keep in mind ABCs, to you're showing me that we're going to dick measure, because that's exactly what it was. The whole, well, I'm an advanced and I can do this. And I'm like, I don't fucking care if you're a critical care paramedic. It's going to be CAB when you have a cardiac arrest. Once you get everything placed, whatever. You want that tube? Cool. You want to do that IO correctly? Cool. I don't care. I'm not going to dick measure with you. But to turn around, take corrective, I would say niceness, turn around and say I'm unprofessional and I was rude. Baby boy, you don't fucking know what rude is until I smack you down with the rudeness and tell you that you do not know how to run a cardiac arrest and you are an ineffective provider. And honestly, I would argue that that's not rude either. That is the honest fact. If you have a BLS and ACLS certification and you genuinely think, fuck the ABCs, I'm going to do an IO, cool. I don't need practice doing another IO, but you know what? That patient needed an airway and she needed CPR. If you can't tell, even though it was, a hot minute ago, it makes me mad.
Just a little bit. So, in light of all that, that segues into the solutions to the problems that we just talked about. So for prioritizing care sequence of events and care on scene, a proper debriefing is important. And with that debriefing, not only should it be articulate and have constructive criticism, as it did in this case, but the reception to that should be a willingness to hear feedback, a willingness to receive said criticism. And when your reaction to said criticism handed to you professionally is, oh, well, that shouldn't have happened. Like this shouldn't be happening. That's rude.
I was allowed to do that.
Yeah, that sounds like a personal problem. And so we need to get that straight, because I'll be honest, the debriefing is a proper formal debriefing isn't super common. Like, and I'll be the first to admit, I don't typically do it unless there's something to talk about. It's usually just, hey, everybody good? Got any problems? Any questions? Okay, cool. Like, that's as far as it goes.
That's how I do it too. When I say debriefing, it's usually only after like just a shit show call. It's usually like, hey, do you have any questions for me? Anything you need to talk about? Something that my paramedic preceptor used to do is after every call, even if your answer is we could have done nothing better, my favorite thing that he did was, is there anything or what went right on the call? Give yourself a pat on the back, especially on the shit shows. And then what could have gone better? Not even necessarily what went wrong. Because, like, let's take that cardiac arrest, for example. Like, yeah, a lot of stuff went wrong. But, like, ultimately, do I think if they had the bags in the house and we worked the arrest in the house, do I think we would have saved the patient? No, unfortunately not. Just because even the coroner agreed that, sudden cardiac event, et cetera. And even if you do everything right, it's just good to know that you need to talk about proper sequence of events.
And it's again, it comes down to the attitude. You need to be in a position where you're willing to hear and are willing to correct. Because sure, you can listen, absorb, and learn all you want, but if you're not actually going to take action on it, then it doesn't do anybody any good.
Well, if you're not going to take action, is you actually learn anything? I mean, I would argue at that point, probably not.
No. So, following that, we talked about there being a lack of investment, both from agencies and providers. The simple solution is invest in this job or go get a different job. Go do something different. And investment looks different for each person, because you're going to have a different kind of investment into this than I am. There's different needs that you have. Each of us has different strengths and weaknesses with this job. And there's different things we can bring to the table, both directly in our patient care, but also broadly speaking for the field, things that we can contribute and invest in. So if you're not willing to invest in anything, then nobody's going to take you seriously. You're going to have a dead end career, and you're not going to benefit any of your patients or your partners. So kind of what's the point if you're not willing to pitch in and carry some weight? You're not helping anybody. You just need to go find a different job.
Well, and even if you're only going to be in the job for, I don't know, a year because you're going to go to medical school or whatever, you should still put your best foot forward, no matter what you're doing, because invest in yourself and invest in others during that year. And you might end up making some really good personal and professional connections that can help you later on. It's kind of the same thing with when you leave a job, try not to lose the job. Don't burn that bridge unless you absolutely have to, because you never know when it's going to benefit you in the future.
Yep. Because everybody talks. Everybody fucking talks.
But what have we learned recently? Not sure.
Well, yes. I was like, everybody runs their mouths. Your reputation will precede you. And sure, there's going to be naysayers like, dipshit McGee over there. And, well, yeah, no, I was the dipshit McGee we were talking about. And yeah, you'll have people that will naysay like that, but ultimately they make themselves look bad, because when the facts are brought to light, you're going to look like a douchebag, to be completely blunt and honest.
Well, what I think is is interesting is when you have the providers that have the bad reputation that still get hired because they try to like fake it with management and they get by. It's like, honey, your reputation is going to catch up at some point, especially if you continue to be a shitbag.
Yeah. Now, if you fall into the category of someone bringing home problems to work, get into therapy. Seriously, get into therapy.
Therapy, learn, self-help, however, for emotional regulation. Like, there's really not another way around it. Like, you can't let your personal life run over somebody else's life, even if their complaint is bullshit. Because ultimately, your job is to be there to literally serve and suck it up.
Well, and when do we define something becoming an addiction versus just a bad habit? Is when it starts to affect the people around you. When you are having detrimental effects to those around you, that's when it needs to, whatever it is, needs to get fucking addressed. And I'm sorry, talking with your coworkers is not the way to do it. That is not the way to get the help that you need. I understand there are situations where peer support groups can be helpful, but for the most part, especially when it comes to anything that's related to mental health and psychology, you should actually get a properly trained professional. And yes, there's a lot of legwork you can do yourself with that. Like it's not a kind of situation where, oh, woe is me, I can't do anything without someone holding my hand. Like, no, get up off your ass, start trying, but go get some professional help. Even if it's just for a little while, even if it's just for a couple months. Something to resolve the issue. Stop bringing your shit to work. Seriously.
Even if it's just coping mechanisms and you realize that, whatever it is that's going on is not going to go anywhere anytime soon. Like, you can still work on, breathing techniques or whatever it is that you need to help you through the shift. Or you need to take some PTO, some FMLA, quit,
Get a different job.
Well, I mean, quit.
I'm just saying in general, like either a different job in the same field or a completely different career.
Yeah, just something.
Yeah.
And then our last one, the solution to the problem of people providing or prefacing,
Prioritizing.
that one, there we go. Prioritizing convenience over care is you got to pull a stick out of your ass. This is our job. This is our, city. This is not a hobby. Studying on shift, like, cool, I'm glad that's what you chose to do, but that is not your job. If you want a job to study, then you need to go to one of the academies that pays you to study. But then you're not working on the truck. Like, if you're an FTO and you're expected to get some instructor certs to do something, you better fucking do it. If, you're not wanting to have third riders, why get a CFS, what was it, certified field training specialist?
I don't even remember.
They
Clinical field specialist. There we go.
Field specialist. There we go. They have different names wherever you are. I mean, yeah, that's what I've always collectively heard them. Or if you're a paramedic and you don't want to run ALS calls and you BLS everything, well, why are you paramedic? Like, this is your job. This is the certification. This is the role and responsibility that you stand for, and you are expected to do the best for patient care.
Oh, I have to run so many ALS calls. Well, you get paid more. Paid more than your EMTs, at least. I know we don't get paid shit, but like you get paid more. So if you're going to expect more money, you should be doing more work or bringing more value, which you often bring the value by doing your work.
And judgment and discipline and classes and all of the things that we've talked about.
Yep. Even if it's a class that you have had before, still take notes in it. If it's your umpteenth time researching BLS, cool. Take some notes.
Well, and I mean, if we're being honest, stuff that we thought was settled keeps changing. Did you know that they just changed again how we're supposed to treat flail segment in the field?
Oh my God, what are we doing now?
Now they're back to positive pressure. Like, I can't remember if it was Master Paramedics or Foam Crap, but I saw one of their videos recently. They had the most recent study, I think, like as of this year or something. I'll have to go back and find it. But yeah, apparently we're back to positive pressure to splint the things, and I'm just like,
Yeah. Yep. Yeah, just tell me what kind of toothbrush I need, and we'll just carry on with life. Like,
That's the point. Even if you've taken a class 52 million times, like medicine is constantly advancing. Apparently, like the whale segment, we can't decide what we're gonna do. I think at this point we would have studies between the sandbagging and the splinting and the deposit pressure and then the nothing and then the.
well, I'm calling it now. I'm calling it now. They're gonna bring KEDs back, like mainstream, not just.
Say, I mean, everybody carries them still.
When was the last time? When was the last time you used one?
See, but here's the thing. They've come out with so many studies now about the detriment of leaving a patient or putting a patient on a backboard. I don't think they'll bring KEDs back. You can roll your eyes.
I don't know.
And they have the pelvic binders now, so why are you using it for a pelvic splint?
But we used to think that giving tons of fluids to traumas was a good thing for them, and magically.
Okay, but that's the point. They've moved past it with spine cords, so why are they going to bring back?
I'm just saying. I have a feeling something like that, some random shit like that's going to come back. It's like, oh, we still need to do this more often now.
KED today, so I'm pretty sure that's the only reason Daniel brings up KEDs.
But when's the last time you put one on? Like, never.
Every semester. You can't play that game with me.
When's the last time you had to put it on an actual patient? There we go. That's the question.
Every semester. Answered your question.
I swear.
He's just mad that I'm right. He's usually right.
You heard it. It's recorded.
You say that every time.
But seriously, how many of you ladies out there willingly admit when your man's is right?
I mean, I always do.
Well, but that's why I married you. No.
Wow, okay. Guess what? It's going to become a problem.
No, I married you because you were not the norm. So, legitimate question. How many of you willingly admit that your man's right? We'll noodle on that. Put it in the comments. Anything else we want to share with the class before we leave?
No. I mean, probably all of the things I've shared so much this week. 6, whatever.
Yeah, all the things. Well, if you learned something, good. Tell your friends about it. If you were offended, good. Probably should be. You tell your friends about that too, so they know how much of a little bitch you can be.
And share the podcast.
Yes.
Make everybody angry.
Might as well. We do it all the time. So,
Yeah,
all right.
my list is growing.
Bye. See y'all.